Why you say? If the patient complains of progressive yellowishness of the eyes and increasing jaundice, no pain.
Yes, sir.
And as serum
CBD
is 15 milligrams.
Yes, sir. CBD is blocked due to the stone. Okay. CBD is blocked due to the stone or the function of the CBD itself.
Normally it's very, in stones, it is very, very rare.
Very yes, sir. Yes, sir.
It's very, very rare. So
more
it's
likely the
almost ruled out. Almost.
yes, sir.
So how will you proceed?
Will you sir? First, do like tourism, sir. Yeah, regarding baseline things and all, and then the goal is to relieve the biliary. Can you hear me, sir?
How will you proceed?
The goal is to relieve the biliary obstruction, and then start the empirical antibiotic therapies. And then patient will be in like for the baselines any CBD is high or not, LFT and LFT, ALP is raised or not, and ischemia spondylitis or not, sir. Then accordingly we will start with the basic antibiotics and fluids, and
what all you will do for the diagnosis?
Diagnosis. So initially I would go with the image ultrasound. Initially, after that we'll ask for MRCP. Then after that we ask for
this patient, the ultrasound, the patient had costly dilated CBD and ISBRD.
Yes, sir.
The gallbladder was distended.
Yes, sir.
Head of the pancreas, head of the pancreas was not able to. It was not evaluated properly because of the presence of gas.
Yes, sir. Yes, sir.
So, what is the next investigation you like to have?
The CT scan, Professor Pancreatic protocol.
So what is the pancreatic protocol CT?
Like thickness of the 1 millimeter thickness of the CT of the pancreas, depicting all the phases.
Which all phases you need?
Arterial phase, delay phase, and portal phase.
What?
Timing 15 seconds.
Okay.
15 seconds, 30 seconds, and 15 seconds, 30 seconds, and 3 seconds up to end of 1 minute.
Okay. Now, Srijana, I have just I'd like you to comment on this video.
Yes, sir.
You want me to rerun it?
Yes, sir. Sir, there is ill-defined hypoechoic lesion in the head of pancreas with dilated IHBRD, sir. And there are no liver lesions, and veins appears to be normal. There is no involvement with the vein, portal vein or SMV. Pancreatic duct is, sir, can you show the video again, sir? Pancreatic duct is mildly dilated, sir. Little prominent, sir. And GB is distended, sir. It is a CA head of pancreas, which is resectable.
Actually, it is not a CA head of pancreas. The pancreas head is looking normal. Basically, only you can see a very small hypoechoic mass in the lower end of the CBD.
Lower end, yes.
Not in the head.
Okay.
It is looking like a lower end cholangiocarcinoma.
Okay.
Right?
Yes, sir.
Nagarajan, what do you do further? Niranjan, Dr. Niranjan, sir. Yes, sir. What do you do further?
I'll do basic investigations of CBP, RFT, LFT, in the CA 99. Okay, and I'll do a ERCP and
Why you need ERCP? The role of endoscopic ultrasound.
yes, sir. Yes, sir. It can be done, sir. US and US
Can be
guided.
done or is it required?
Huh?
Is it required or it can be done? So actually,
It is required, sir. It is
required.
Yes, sir.
Do you need a biopsy proof before surgery?
No, sir. No need.
Why do you want to do EOS guided biopsy or? So actually, the preoperative diagnosis, preoperative proof of malignancy is not required. It's almost clear that it's a malignant growth in the lower end of the CVT and it's resectable. So it is not required unless and until. What is the need of US guided biopsy in these kind of cases? When do you require it?
If you plan for neoadjuvant chemotherapy,
when you feel it is unresectable, advanced disease, to plan neoadjuvant palliative treatment.
If you want to go for a straight away upfront surgery, no need of biopsy proof. But if you require any preoperative chemotherapy or chemoradiotherapy, in that case, or you require a chemotherapy for a palliative reasons, only in those cases you require a biopsy proof, otherwise don't. And what is the need of biliary stenting? Suppose the patient is upfront resectable. Why you require a biliary stenting? Do you really require biliary stenting in these cases?
it's better to have, sir, to reduce the potential biliary obstruction. To better to have the stenting, sir, initially. Then we can proceed with the surgery later on, sir.
The biliary stenting is required in cases where the bilirubin level is very high. If it is more than 20, then it is required. Or if you want to wait for something like the patient is having hyperproteinemic, patient is having azotemia, nutritionally down, only in those cases we want to build up the patient for some time. Only in those cases, or if the bilirubin level is more than 20, otherwise it is not required. You can straight away go for the upfront surgery. Right?
Yes, sir. Cholangitis. Cholangitis. Yes, sir.
Cholangitis.
Yeah, of course. Yeah, basically cholangitis or the azotemia or the hypoproteinemia. Like the patient is having fever only, then you will require a stenting. Otherwise, because what is the disadvantage of having stenting, preoperative stenting?
Yes, sir.
Increase the chance of infection post-operative.
Yes. The biliary
infections and
septic complications are more after surgery if you have a biliary stent. And how much time you wait for biliary stenting?
4 to 6 weeks, sir.
Yes, it should be more than a month so that the liver functions, they come back to normal. So, is there a role of PET-CT in these cases? Is it required? Anybody? Lingaraja?
We can ask for, but for optional things, not compulsorily. If we can put any other medicine that we can ask for is not required.
Anybody else? Srajna?
Sir, no need of PET-CT. But if CA19-9 is more than 500, that is one of the soft indication. But because of high tumor load in CT anyway, there are no suspicion of liver mets and all. So as such, not required, sir.
As such in the guidelines, the role of PET-CT is not there. If you get a good MDCT and a CT chest, that's not required. And moreover, the role of CA19.9 in jaundice patient is not there. Unless it's spurious. If the patient is jaundice, then you cannot rely upon
cholangitis. Not.
So do you require any preoperative preparation in these patients? Like the patient is fit, I mean, patient's protein is okay, patient is fit, young, good performance status. Do you require anything else in these patients?
Sandeep, it is there, sir. Coagulopathy, if there's coagulopathy, we have to correct.
Your voice is not good from your end.
Sir, if there is coagulopathy, we have to correct it with vitamin K injections.
Yes. That is the only thing you do at this moment. You have to see for the look for the coagulation factors. If there is a long PT, you have to correct it before surgery. Right? So this patient had CA19.9 was 64, CA 2.6 and CA 125 7.9. Do you require CA 125 in these cases or no? CA 125. Any role of doing CA 125 in these cases? CA 125 does not have much role in these cases, but in carcinoma endopancreas, if the CA 125 is raised markedly, in general it is seen that the prognosis is poor in these patients. So this can be done preoperatively so that we can have a post-operative evaluation and post-operative follow-up in these patients, right? So 125 as such is not, it does not carry any meaning in diagnosis or in management, but somehow it tells about the aggressiveness of the tumor. 125 is more, the chance the prognosis is bad in these patients, in carcinoma endopancreas, not in cholangiocarcinoma, right? And this patient had 1.8 into 1.2 centimeter mass in the lower of the CPD. FNAC, because the patient wanted a proof before surgery, so we had to get this FNAC done. So it was positive for malignancy, and stenting was not done. Routinely, we do not do any stenting in these patients unless until the patient is having cholangitis or azotemia or hypoproteinemia, right? So, any role of diagnostic laparoscopy before proceeding for surgery in these patients?
Yes, sir. Any meds in the patient view or in the viewer of some very small meds can be wrote in the imaging can't be seen, sir. Like in the CT scan, less than centimeter meds in the CT scan can't be seen. So if you need in the D-lab, we can see any small meds are there or not in the nearby area and local thing you can see advancement and all. You can go for either palliative or the depending on the clearance.
No, in general, all the GI malignancies, they have role of some role in diagnostic laparoscopy, because before proceeding, even if you are going for open surgery, you should always do a diagnostic laparoscopy, because in 10 to 15% of the patients, like in carcinoma endopancreas, stomach, and CGB, these patients they have some micromets, I mean the small mets in the peritoneal surface. So if you do diagnostic laparoscopy, you can avoid unnecessary laparotomy in these patients. Yes. Dr. Ranjan, you want to say something?
No, sir.
No? Dr. Reis, any comment on this?
Sir. You routinely do diagnosis for all the.
So this patient underwent minimally invasive pancreaticoduodenectomy with a pancreaticogastroscopy. Normally we do pancreaticojejunostomy, but this patient had a very small pancreatic duct, so we wanted to do Duncan technique, and so we did pancreaticogastroscopy. And on POD1, the patient had hemorrhagic aspirate from the Ryle's tube. So what do you do? If you have a significant hemorrhagic aspirate from the Ryle's tube, what do you do then? What's the next course of action?
I'll examine the patient for reporting initial stages. I'll check what's the total digestive output in the past 24 hours and what exactly is the output. Is it frank blood or it's just hemorrhaging or bile with blood mixed? I'd like to quantify. I'll like to take in heart rate, BP, HB, hemoglobin levels.
What else? So this patient nearly approximately 700-800 ml of bloody aspirate from the Ryle's tube, and after that it was not the blood stopped. The patient was hemodynamically okay except the tachycardia, and hemoglobin drop was more than 3 gram/% overall. So we need to transfuse 3 units of blood. So what kind of grading you will say this was a, what kind of grading it was post-pancreatectomy hemorrhage? Which grade it will be called? Hmm? It will be called grade B. So basically required transfusion more than 3 units, and the hemoglobin drop was more than 3, and it will be called early severe. It will be called grade B. And what investigations you would like to do at this stage?
We'll do an upper GI endoscopy, sir, to look for any like active bleed or
On day 1, when the bleeding has stopped, on day 1 you will like to do endoscopy. This.
At this point, I will not do anything. I'll wait and watch the patient's hemoglobin status. I'll do repeat hemoglobin.
Dr. Rais is not answering. Dr. Rais?
Sir, if the bleeding has stopped completely, we should wait and watch.
Yes.
We should monitor hemoglobin 6 early and watch for coagulation parameters also. We should watch for melena also. In case bleeding is persisting and we are doubtful that bleeding is persisting the next day with an HB drop or received aspirate having, we should proceed with a CT angiogram.
So basically, this patient, we did not go for endoscopy, but we got the CT done. This is the CT report. This is CT films. So what are the findings? You want me to run it again?
Yes.
So there is a collection in the lesser sac.
There is a hypertension made in the stomach as well as a collection in the sac. What will you do next?
Our primary suspicion is a hematoma. We should do an, if the hemoglobin is stable, we should do a serial.
Your voice is not clear.
And do an ultrasound screening the next day to make sure. Yes, sir, can you hear me?
No, I cannot hear you clearly. You're audible but not clear.
Sir, can you hear me?
Yeah, I can hear you.
Sir, sir, if the HB is stable, we should watch with the serial hemoglobin measurement. If the next day we can do a ultrasound screening as well to see if the size of the hematoma is increasing or if there is any, otherwise if there is any variation in the hemodynamic parameters also.
Do you think this collection is a blood? This is a blood?
So there's no much enhancement seen in the collection.
It's not dense. It is not a dense. It's quite a hyperfluid type. It's not a dense collection.
Yes, sir.
So would you like to do aspiration or a placement of PCD in this case?
PCD placement will be better, sir.
Yes. This is not looking a blood collection.
Blood collection.
This is looking like the patient had a bleeding from the suture line in the stomach, and following that must have leaked. That's the tentative made. It must have leaked at that time. So there's a collection in the retrogastric area in the lesser sac. So we need to place a PCD here. do aspiration of PCD to confirm whether patient is having a leak or just a bleeding, intraperitoneal as well as a intraluminal bleed, right? So we started the PPI infusions, continuous RT aspirations, intracervical guided pigtail placement on PEOD1, right? And it drained the drain fluid mileage was more than 7,000, and this drain showed bilious collection. It had a bilious, so that means the anastomosis leaked. The possibility of leakage, anastomosis leak in this case was basically either because of technical fault or because of distension of abdomen, distension of stomach, because of a lot of bleeding, intraluminal bleeding. So what next you will do? So you will manage the patient as it is.
Conservative.
Can we begin octreotide in case of pancreatic leak?
Octreotide, we saw octreotide. Anyway, we always give octreotide after a pancreatic transaction. On the day of surgery itself, we give octreotide and we give it for 5 days. So that was already running. So if it is not there, I mean, you don't put a patient on octreotide on day of surgery, then you can start octreotide at this time, right? So the patient had multiple episodes of fever. Then what do you do after that?
We have to trace cultures and start culture-specific antibiotics.
Drain culture and hold it.
We need to do further imaging to look for any undrained collection, any other undrained collections, and then if required, put a PPD cultures, complete antibiotic.
Okay. Same thing we did a CT scan again, and it showed localized collection in pelvis. So the PCD again, another PCD was placed, right? Then what do you do after that?
You have to maintain nutrition of the patient.
Okay, and put the patient broad spectrum antibiotics, and start. We generally put a feeding jejunostomy. Start the nutrition from the feeding jejunostomy, not from the by mouth. And on POD10, the patient suddenly had severe pain abdomen with tachycardia and hypotension, and there was a gross hemorrhagic drainage from the drain side, the right side drain. There was a gross hemorrhagic drain. So what do you do at this stage?
You have to do CT abdominal angiography to check for any aneurysm or active externalization.
Okay. Anybody else?
CT angiogram.
CT angiogram. And simultaneously resuscitate the patient.
Resuscitation and return vision and eye fluids.
Yeah.
Then you move to CT.
This was the CT picture of the. Dr. Rais, please comment on that. You want me to read on it?
Yes, sir.
Tell me the findings. Anybody?
So there is no apparent contrast externalization. There is no active bleeding. I am not able to appreciate any aneurysm, sir.
Dr. Lingarajan?
But there is collection all over the leg. No.
This is the collection.
Yes, sir. Yes, sir.
All bowel loops.
Yes, sir. Yes, sir. Collection is there.
This is collection. This is hematoma. And what else you can see? Dr. Rajna, can you see anything else in this? Dr. Lingarajan, Dr. Niranjan, anybody? Again, I am running it. This is SMA.
SMA.
This is the blush you can see.
Okay.
This is the blush you can see.
Yes, sir.
This is extravasation contrast in this area. There is some branch of SMA is bleeding. Just a branch of SMA. So what do you do?
We can do
conventional angio. And then
Feasible coil embolization can be done, sir. Diagnostic angio and therapeutic, we can do coil embolization of the particular.
And how will you grade this hemorrhage? What kind of A, B, C?
C.
Sir, it is C, sir.
C, sir.
C.
C. Late.
It's a late and severe.
Late severe, yes, sir.
Yes.
He was having gross hemodynamic instability, right? He was after this, and the blood transfusion was given more than 6-7 units in this case. So it's a grade C. So the coil ambulation was done, and repeat CT angio showed no active contrast. 7 units of RBCs, this PRBC were given, and patient became stable after that. Then after that, he required repeated PCDs for the residual hematomas because he was having running fever. So we thought this hematoma is infected, so we had to place another PCD in that. The patient was discharged in 32, day after 32, right? So what next? The final histopathology report was cholangiocarcinoma lower end, PT2 and 0, right? What do? Do you go for any adjuvant chemo after that? Any therapy, adjuvant therapy? Anybody?
For most periambular lesions, we still proceed with post-operative chemotherapy, sir.
So anybody who's more than T1 cholangiocarcinoma, we have to go for adjuvant chemotherapy. Which chemotherapy?
Gemcitabine
Gemcitabine based. Right. Okay. Good. So we come to the next case now. This is a 28 years female, no comorbidities. She presented to us with pain in the right hypochondral region. In fact, she did not come to us at the first time. She went to somebody else. She presented with pain in the right hypochondral region, nausea, vomiting, fever, decreased oral intake. So what are the possible diagnoses?
acute calculus cholecystitis.
And
Liver abscess.
Liver abscess.
What else? Hepatitis.
Hepatitis.
Hepatitis, sir.
What else?
Xerositis.
Mm-hmm.
Viral illness with xerositis.
Colitis. Can the patient have colitis? Standing colitis, right-sided colitis? No. Can have. So how will you proceed? Dr. Lingarajan, how will you proceed after that?
Sir, initially we'll do like basic CBC, LFT and all. After that, investigation, ultrasound to look for any like liver or the stones in the gallbladder. Wall thickness, any collection around can.
Okay. So this was the finding. Dr. Ranjan, what will you do?
MRCP.
What is the finding? Gallbladder mass, thick gallbladder sludge and bilateral renal calculi.
Bile
was normal. CBD size was normal. Gallbladder wall was thick. There was a gallbladder mass. Small renal calculi. Small. Just like convulsions. How will you proceed after that?
I'll do a CCT abdomen, sir. To
look for what?
Look for the GB mass. to get more information about the GP.
Will you have to do MRCP or a CT scan?
Will be better, sir. Because suspecting GB mass, we want to see the vascular involvement and all.
So basically, the patient is not jaundiced. LFT is normal. CVD size in normal in ultrasound. So there is no point going for MRCP. Yes, it is basically to have a good contrast enhanced CT scan, right? So this is the finding of CT scan. Notarize. Can you tell me the findings, or do you want me to rerun it?
Second read. So CT shows there is bilateral pleural effusion, as well as there is a distended GB with a enhancing mass lesion in the fundus, along with some pericholecystic fluid as well. And there is inflammatory stranding, fat stranding also surrounding the GB.
So the diagnosis is?
It could be a perforated GB, possibly. I'm not able to make out glucose discontinuity.
Anything else?
Xanthogranulomatous
Xanthogranulomatous gallbladders normally they don't present like a distended gallbladder. Their contracted is grossly thickened wall with a contracted gallbladder, right? So this is acute, severe acute cholecystitis with a mass inside. So the diagnosis is, tentative diagnosis is?
Gallbladder with
acute cholecystitis. What else you do after this? What will you do? Yes, Dr. Srajna, what will you do?
A course of antibiotics for the cholecystitis.
Good.
And meanwhile, we will optimize the patient, see how she is responding with antibiotics, like fevers are decreasing trend and all. Then because there is bilateral pleural effusion, it could be reactive also in view of acute reactive infection. So once the infection is decreased, we will consider a repeat imaging by PET-CT to rule out metastatic disease, sir.
Why PET-CT? Is there any role of PET-CT in CAGB?
Tumor looks like locally advanced, sir, in CT, and there is bilateral.
How it is looking locally advanced?
Sir, infiltration in liver is seen, sir.
No, there is no infiltration. There is only an intraluminal mass, and rest the gallbladder is inflamed. So there is no local infiltration. So do you really require PET-CT in these cases?
No.
According to guidelines, basically you require only a abdominal CT and a chest CT. That's all. And
T19
and the tumor one.
markers.
All four markers.
CA and CA19.
And CA.
See, anything else you'd like to get it done? Yuva Walker was CA was 2.5 and CA 19.2.3. 19.9 was 2.3. So how will you proceed now?
So 4 weeks for the cholecystitis to resolve. And then we will consider for surgery radical cholecystectomy.
Okay. So do you require an ultrasound guided FNAC in these patients to rule out any malignancy in GB mass? Do you do?
Not
We
required.
don't usually do FNAC for GB mass.
Anybody else? Anybody's for FNAC?
If locally advanced disease or unresectable disease, then we can consider for FNAC to give neoadjuvant therapy.
True. So basically, we do not do FNAC in CAGB unless until you need to go for any palliative chemotherapy or a NSCT. So there's no need because there are chances of spill, right?
Yes.
So, but it was this case was referred from somewhere else, so they did the FNAC, and they showed that there was an neuroendocrine tumor of the neuroendocrine carcinoma of gallbladder, right? So how will you proceed now? On FNAC it was neuroendocrine carcinoma.
We'll send serum chromogranin.
It's 124. Then how we proceed? Niranjan?
DOTA PET scan to
Why you require DOTA PET scan? Why require a DOTA PET scan? When do you do DOTA PET scan? It was a neuroendocrine carcinoma. So the cells are poorly differentiated in neuroendocrine carcinoma. So DOTA knock PET scan may not show anything. Rather, in neuroendocrine carcinoma, you require a PET CT, FDG with PET CT, right? Not the DOTA PET CT. So if there's a tumor is well differentiated, only then the DOTA PET CT is of useful. Right? In these cases, you get a FDG PET. So these are the findings of FDG PET CT. So how will you proceed? So it is looking like a localized.
localized.
So how do you proceed? What do you do then?
Radical cholecystectomy.
Go with TLAP, sir. First, initially, diagnostic laparoscopy, and then after that, we can take intraarticular node projection also.
Good. This case, because this case was having acute cholecystitis with the neuroendocrine carcinoma, it needs to have a radical cholecystectomy. But before that, we should proceed for diagnostic laparoscopy for any peritoneal disease, and as well as before starting the radical cholecystectomy, you should always do the sampling of intra-aortic lymph nodes, because if they are positive, then you have to abandon the procedure. So that part can be done by laparoscopy, and because it was acute cholecystitis, so in that case you need to have open radical cholecystectomy, because in inflamed gallbladders you can do laparoscopic radical cholecystectomy. But whenever you have a acute cholecystitis, you should always go for open, because the chances of breakage or spillage of the gallbladder is more, right? So basically, we proceeded with the diagnostic laparoscopy. Did the entire iridocaval lymph node sampling, which was on frozen, it was negative. So we opened the case, did a open radical cholecystectomy. Right. So on POD3, there was a fever, tachycardia, drainage of serosanguinous fluid approximately 50 ml. How will you manage this case now?
Stabilize the patient, resuscitate the patient. We'll see the cause for tachycardia. It could be because of bleed also. It could be because of dehydration. So we have to monitor that all and give adequate fluids, monitor hemoglobin, and monitor the drain output.
Hemoglobin was stable, TLC was raised.
So we can send a drain bilirubin as well, see if there is any bile leak or not.
It was okay.
And ultrasound, sir. And any collections, any undrained collections.
So you do the ultrasound. So the same was done. There was a 12-14 cc fluid in the gallbladder fossa, multiple air fluid pockets, bilateral mild pleural effusion, right? So what do you do now?
Aspiration.
We did the CT scan to further categorize the collection. There is a small collection 7 by 7 centimeter in the gallbladder fossa, and the tip of the drain was placed inside the collection. The catheter was already there in the. So we flushed the drain. Didn't do anything else. Nothing else was required. So the drain was removed on POD7, right?
Yes.
So the stage was this is the histopathology report. PT2 and PT2B N1. It was in favoring the neuroendocrine carcinoma with all these IHCs, right? Then how will you proceed now?
So we can start them on somatostatin for neuroendocrine tumors. We usually start them on somatostatin agonist.
You're saying octreotide depot? You're talking about?
Yes, sir.
What does it do? When do you give it?
Usually it is it is poorly differentiated. It does not have much effect. It should have somatostatin receptor uptake. Usually.
If you have done a complete job, radical cholecystectomy, even if it is a well differentiated or intermediate grading neuroendocrine tumor, and you have done a complete radical cholecystectomy, all the margins are free, everything is fine. So why you need octreotide treatment after that? You really need that, even if it is a well differentiated.
Follow PET-CT after.
So you got to just follow the patient. No need of any adjuvant therapy. But this was a case of neuroendocrine carcinoma, right? Stage 3. So what will you do?
Three-monthly follow-up with ultrasound and serum chromogranin.
Don't go for any adjuvant therapy. So stage 3 neuroendocrine carcinoma, so we have to go for a adjuvant therapy. So we started with this cisplatinum with etoposide. 6 cycles at least we'll give. Right? Then you have to follow this patient every 3 monthly for 2 years. Then 6 monthly for 5 years. Right?
Sir, do we need to do PET-CT during follow-ups?
Yes.
Yes.
In follow-up, basically we follow up the patients with the 3 monthly ultrasound and 6 monthly CT scan. There's no need of PET-CT in these cases. PET-CT we do only when you have a suspicion which is not the metastasis is there, recurrence is there, which is not clear on routine CT, good MD CT, only then we go for PET CT, otherwise it is not required. Follow-up can be done with the CT scan. Right?
Yes.
Moreover, the serum chromogranin was slightly raised in this case, so we can follow up the patient with serum chromogranin also 3 monthly. Right? Anybody want to ask any question? Okay. Now can we proceed to the third case?
Yes, sir.
Okay. 3. A 60 years female with the diabetes and hypertension. She presented to us with vague abdominal pain. No other pain in the past. No history of similar complaints or severe pain in the past. On ultrasound, it was seen like a 5 into 4 into 4 centimeter mass nodule in the and vascularity in the body and tail of the pancreas. The cystic mass in the body of the pancreas, right? So what will you do after that? What is your tentative diagnosis, differential diagnosis?
Cystic neoplasm for pancreas or NET also because of high vascularity.
What else? You're right, tentative diagnosis is cystic neoplasm of the pancreas, but we cannot rule out the neuroendocrine tumor, right? So what will you do on this?
CT pancreatic protein.
Okay. So there was a cystic mass in the pancreas. There's no communication with the pancreatic duct, right? So what will you do after this?
Patient. We plan for surgery, sir. Distal pancreatic tumor.
Why you want to do surgery?
Mucinous cystic neoplasm suspicion.
Suspicion. Can it be a pseudocyst?
No prior history of
pancreatitis.
No comment on gallstones or anything like that.
I mean, less likely.
So basically the diagnosis was cystic neoplasm of the pancreas or a pseudocyst. So to differentiate that, what we do?
EUS guided fluid
Aspiration of the system.
Yes, sir.
analysis.
What is it?
EUS guided
Endoscopic ultrasound.
And what do you do with that?
Fluid aspiration for analysis of CEA amylase.
In US, it was a hypoechoic lesion in the body of pancreas, 4 into 4.5 centimeter, with necrotic collection, and they showed a communication with the PD. That was a doubtful communication, but they suggested that it is there is a communication. So, what is the differential diagnosis then?
Junction IPMN.
Pseudocyst and?
IPMN.
Yes. So there was a doubtful communication with the PD, but still we considered there was a possibility of mucinous cystadenoma also, right? So, but our gastroenterologists were, absolutely sure that's a pseudocyst. But as we
this finding of ES, it is more likely to be pseudocyst.
But there was no history of pain at all. There's no previous history of pain at all. So we were very sure that there's no history of acute pancreatitis. And this kind of pseudocyst cannot be without pain, right? So we persisted with EUS guided aspiration. on aspiration there was thick mucoid fluid, and CA was 40,000. So what does it mean?
Business system.
Business.
So the CA more than 40,000 is highly suggestive of mucinous cystadenoma or IPMN, right? So I mean, what is the cutoff line? The cutoff line of CA. How much level of CA should raise your suspicion?
1,000.
No, it's more than 110. So nearly 200, right? Okay. So we decided to go for surgery. What surgery you will do? What surgery you will do in this case?
Distal pancreas.
Spleen sparing or non-sparing? With spleen or without spleen?
Without string, sir. Because without the string.
Okay. Can we do median pancreatectomy in these cases?
Distal pancreas should be of minimum 5 centimeter further.
And
it should be completely benign lesion.
yes. So median pancreatectomy is done only in benign lesions or very low malignant potential lesions, and there should be significant residual teal of the pancreas should be there, right? So in this case, it is not advisable to do median pancreatectomy. So distal pancreatic splenectomy should be done, and spleen preservation can be done if the vessels are nicely bare, they are free. But if suppose they are involved either with the inflammation or with the tumor, then the complete pancreatic splenectomy should be done, right? So we did this laparoscopic distal pancreatic splenectomy. On day 6, there was a milky drainage, approximately 600 from the drain. What it is?
Kindly.
Okay, how will you make the diagnosis?
Drain fluid triglyceride.
110. You can diagnose.
Come again?
More than 110.
Yes, triglyceride more than 110 should make a diagnosis of cholecystitis or chyle leak. So what do you do?
Conservative management, NCT diet.
First step is how do you manage, and what kind of grading is this? On which grade of chyle leak? How will you classify the chyle leak? According to ISGPS, there must be some grading.
Grade B.
Grade B. How do you classify grade A, B, C?
A is just biochemical.
B is
Output between 200 to 500, and it is controlled with conservative measures. And grade C is requiring interventions.
So grade B is whenever you require an PCL drainage, there is a prolonged drainage, but the patient can be managed with dietary modifications or TPN in the ward. Grade C is when you require repeated ICU admissions, or there is a sick patient with a chance of mortality. It's a grade C. So this was a grade B. So how we proceed in these cases? Like initially, what you do? What is step 1?
See for fever spikes, TLC count, ultrasound to check for collections, and then start patient on medium chain triglyceride diet,
Okay.
and monitor drain output, trend of the drain output.
Okay. Do you do some imaging also before starting the management?
To check for any residual collections which are not draining, you can get a CT.
What is CT film? What do you see?
Collection.
This collection.
But drain is in situ only. So we can aspirate and see if it is blocked or so.
So we flush the drain, we started draining, right? So drain is in situ. Right? Now how will you manage? Do you do anything else also? Anything else you do?
If the chyle leak is persistent, it is not decreasing.
At this stage, there is no need of any further investigation. If it continues to leak and the output increases, then maybe lymphocytes are.
What imaging you do? What kind of lymphangiography?
Yes, I think.
How do you do the lymphangiography? How do you perform the lymphangiography?
We will inject a dye at the
web space.
first and second, first web space.
And
Simultaneously accessed. Okay.
What else? You can inject a dye from the web space, and anything else you can do? Any other method?
Percutaneous injection directly into
Inguinal lymph nodes. You can, inject the dye, the continuous infusion in the inguinal lymph nodes, and then do the lymphangiography, like we done in this case. Now, what are the findings? You want me to rerun it?
is that
So there was no leak. The entire crescent can be visualized nicely, and there is no intra-abdominal leak from anywhere. So it is the lymphatics from the intestines they were leaking, right? So what do you do now? How do you manage? What is the first step? Rise. He's not speaking.
Nutrition.
so parenteral nutrition, right? So the patient on TPN.
The first thing is you should always alter the diet only. Start the patient on
Initially MCT diet.
Right,
If
yes.
it is not if it is not improving with MCT diet, then we have to keep the patient NPO, start him on parenteral nutrition.
Bravo. So anything else you can add?
antibiotics? They're more prone for
Infections. So you have to give broad spectrum antibiotics, put the patient on TPN, NPO, and anything else?
Gangrene collections, we should try.
Anything else which can help?
Octreotide.
You can use octreotide. right? And you can use orlistat also, but the overall complications and side effects of orlistat is very high. The octreotide also has some limited role. In low output drainage, the octreotide can help, right? And what is the indication of surgical management in these patients? So in this case, basically we started octreotide at patient kept on TPN. Patient improved, but suppose the patient does not improve, then what do you do? What do you do?
We'll continue on conservative management. So because in lymphangiography we couldn't see a clear site of leak or something. So even if we go for surgery.
So if suppose the patient is having continuous high output drainage, the patient is having low TLC count, patient there is a likelihood of getting infections, patient is going nutritionally down, then you have to do something. What kind of surgical endeavor you can do? What all surgeries you can do? Because the patient leak of chyle was not seen on the lymphangiography, but the person may be having leak from the intestinal lymphatics, so that you can go for the surgical blockage of these leakage areas. Beforehand, you have to give a creamy diet. You give a creamy diet before the surgery, and then you can see the leakage of chyle intraoperatively, and you can block them. And what else? If the patient is having gross ascites, then what else you can do? You can go for the peritoneal venous shunt. It's a rare. It's required very rarely, but there is another alternative you can have. Right? Okay, I think we have covered 3 cases, and the time is also over. So we can we stop now? Is there anybody on the hello? So anything else?
Just check if there are any questions in the chat box, sir.
I don't think there's any questions in the chat box. I don't think anything in the chat box.
Okay, excellent, sir. So thank you very much, trainees and faculty members, for joining the session. Thank you.
Thank you so much.